Hello and welcome to Everybody Podcast. I'm your host, Daria Matza. I recently came across an article about fat shaming being linked to greater health risks, and I couldn't wait to interview the lead researcher, Dr. Rebecca Pearl. She's made it her life's work to study the consequences of weight stigma. A little heads up, she uses the word obesity and does some work with weight loss surgery, but I was sure to discuss this in the interview. She also uses the word comorbidity, which I'm kind of embarrassed to say I had to look up. So for those of you who need Merriam-Webster like me, comorbidity is the presence of one or more additional diseases or disorders co-occurring with a primary disease or disorder. Let's get started. For people who don't know you or your work, can you just talk about who you are and the work you're doing currently?
So I'm a clinical psychologist. I'm an assistant professor of psychology in the Department of Psychiatry at the Perelman School of Medicine at the University of Pennsylvania. My research focuses on weight bias and stigma, so examining public attitudes toward individuals who are perceived to have excess weight, how we might try to change those attitudes, as well as how weight stigma affects individuals with obesity in terms of their mental and physical health, and also working toward trying to design interventions to reduce the internalization of that stigma and the downstream negative health consequences.
Okay. How did you get started with this work?
Well, weight stigma is so pervasive. I mean, it's hard to go anywhere without seeing messages in some capacity in the media or in conversation that have a pejorative tone toward individuals with obesity. So I started getting interested more in the internalization of it from working with patients with obesity and really seeing how powerfully these messages affect lots of folks, certainly not everyone. This internalized stigma negatively affects their daily life in terms of their mood, as well as their motivation to keep engaging in healthy behaviors. It can be very demoralizing when someone's constantly being bombarded with stigmatizing messages that they're not good enough because of their weight. And at this point now, there is research to corroborate those clinical observations that myself and others have noted. Research showing that when folks internalize weight bias, they have more symptoms of depression and anxiety, and also have less self-efficacy or confidence to engage in healthy behaviors.
Interesting. When you use the word weight bias internalization, can you just talk a little bit about what that means for us folks not in the scientific world?
So internalized stigma just generally refers to the idea that people who have a stigmatized identity are aware of the negative stereotypes about their group. They agree with those stereotypes and they apply those stereotypes to themselves. So in the context of weight, this is when folks who have a higher body weight are aware of negative stereotypes, for example, that people with obesity are lazy or lack willpower. They agree with those stereotypes and then they apply them to themselves. So they're calling themselves lazy. They're thinking that, well, I just don't have the willpower to lose weight or make these changes. And as a result, they're self-stigmatizing or devaluing themselves because of their weight.
When you look at body shaming and weight discrimination in our society, what are some of the most egregious examples that you see of this?
That might be a tough one to answer. This obsession with weight and that it's our business what somebody else's weight is really pervasive in popular culture, for sure. Without getting too political, it was an interesting examination of weight stigma and discrimination during the campaign season, when, of course, President Trump got a lot of attention drawn to past comments he had made about a former Miss America contestant, as well as in one of the debates itself, he mentioned a 400-pound hacker who might be behind the leaks or something of that nature. And so it was interesting to see the press actually bring more attention to the issue of weight discrimination in that political context. And then other examples, I think you do sometimes see public health campaigns that might be well-intentioned and really, wanting to help people improve their health and motivate the public in that way, but misguided in presenting messages that are very blaming and shaming toward people with obesity without really providing any productive health message.
Yeah, that's helpful. We just did a little campaign on Instagram that was called Tabloid Takedown.
Ah.
We took this tabloid of Kirstie Alley, which was just horrific, what they were saying about her on the cover of this magazine, and then we photoshopped it to say nicer things. But I definitely, I was having this moment with that in the grocery store because I was with my little girls, and we're just standing in the grocery store, and they were looking at gum or whatnot as we were waiting, and I was realizing this stuff is just getting into them. It's even if I am perfect in the way I'm parenting them around their bodies, which I'm probably not, this is getting into them by standing in line to buy food at the grocery store. And I was just feeling so disturbed by that.
Yeah, and we know that these weight-biased attitudes start at a very young age. So as young as preschool-age children in studies have been documented to prefer thinner peers to overweight ones and to not want to be friends with the overweight peer, and, you know, as well as other kinds of internalized thin ideals and body image messages that because of all this exposure really can become internalized at a young age.
That made me feel a little tear for kids out there. Would you mind talking a little bit about maybe your personal story and how, I don't know, maybe there isn't a connection, but is there a part of your personal story that led you to be interested in this kind of work?
That's an interesting question that I have not been asked in a long time. So I was a dancer growing up. So of course, body image is just very salient in that world. And I think that's when I first became interested in the concept of body image. I also do, in my family, have a family history of obesity. So that's, always been something that I've been exposed to from the health side of diabetes and whatnot. So I think, from those two experiences, I was kind of primed to just think about weight and think about the consequences, both socially and health-wise.
Mm-hmm. What kind of dance did you do growing up?
I was a competition brat, so I did, everything, tap, jazz, contemporary, and ballet.
Yeah, that must have had some intense body image pressures in that world, I imagine.
Yeah, I mean, I was lucky. I was in a studio that was, a very supportive, positive studio with, supportive, positive teachers. But it certainly is a salient issue.
Yes, absolutely. I found out about you more recently because it seems like this recent study you did is getting a lot of press. And I was curious if you could talk about that study. And then I was also just curious about why do you think this is getting so much momentum in the press?
So I'll start by describing the study. So in this study, my colleagues and I were looking at the relationship between weight bias internalization and cardiometabolic health in individuals with obesity. So we had a sample of patients who were enrolled in a weight loss study. So these were treatment-seeking individuals. And at the start of the study, before they started any weight loss, we did all sorts of baseline assessments, both for health and for psychological variables. So they underwent a medical screening in which they had blood draws, and that allowed us to measure fasting glucose, triglycerides, and HDL cholesterol. They also had their blood pressure measured and their waist circumference measured. And those 5 components are all part of something called the Metabolic Syndrome. So if people meet 3 of those 5 components, they're diagnosed with metabolic syndrome. And this is a syndrome that's associated with increased risk for diabetes, heart disease, and all other kinds of obesity-related comorbidities. At baseline, participants also completed questionnaires that included a depression screener, the Patient Health Questionnaire 9 or PHQ-9, as well as the weight bias internalization scale. So this is a widely used measure of internalized weight bias that assesses the extent to which individuals agree with negative weight stereotypes, apply them to themselves and devalue themselves because of their weight.
Before you go on, what does that look like?
So it's an 11-item scale, and it asks patients to rate on a 1 to 7 scale how much they agree with 11 different statements. And the statements include items like, I hate myself because of my weight, things like, feeling like they're not attractive enough for anyone to want to date them. So it's a mix of different stereotypes and ways at getting in that negative self-perception because of their weight. And then the scores are averaged, and that creates an average score that can be looked at as a continuous measure, which we did in this study. And then we also divided people into high weight bias internalization scores versus low based on tertile scores. So we looked at the associations at baseline between weight bias internalization and whether or not people had a diagnosis of metabolic syndrome. And we controlled for, statistically, we were able to control for other variables that might affect metabolic health, like demographic characteristics or depression. And so we found an association overall between weight bias internalization and having greater likelihood or greater odds of having a diagnosis of metabolic syndrome. And when we looked at the separate components of the syndrome, it looked like triglycerides were the driving force here. So there was a higher odds of having high triglycerides when people had high weight bias internalization. And as I said, when we divided participants into high versus low internalization, the participants who had high weight bias internalization had 3 times greater odds of meeting criteria for metabolic syndrome and 6 times greater odds of having high triglycerides than the patients who had low weight bias internalization. I should say we also controlled for BMI, body mass index, in this study, and most studies of weight stigma do this, really to emphasize that this is above and beyond the effects of weight that we're seeing these negative health outcomes.
Is there research that shows high triglycerides being connected to stress? Is that?
Yes.
Okay.
Yeah. So that's a good point, because cardiometabolic health in general is associated with stress, or stress is a vulnerability factor for it. And so a lot of these measures, or a lot of these outcomes, like blood pressure, of course, and triglycerides, could be affected by behavioral factors, right? Like eating an unhealthy diet or not exercising. And they could also be affected by some kind of endogenous stress response. So that's something that definitely requires further research to parse apart what's the pathway by which weight bias internalization might be affecting these health outcomes or might be associated with these health outcomes, because both are actually viable pathways. So on the behavioral side, as I mentioned before, people who have more internalized weight bias have less motivation or less confidence in their ability to do things like exercise or eat healthfully. And so it could be that when people are feeling badly about themselves because of this internalized stigma, they're not engaging in those behaviors as much, they're not engaging in healthy behaviors, and then that's negatively affecting their health.
So are we still not sure if it's that, or if it's just the stress itself creates a higher triglyceride? Is that not clear yet?
That's not clear, right? So that's where there needs to be more work. So there have been studies, not of internalized weight bias, but of just experiencing stigma from an external source or experiencing discrimination. There have been studies showing that folks who experience weight discrimination or in the laboratory are in a stigmatizing situation will have like higher cortisol levels, which is a marker of stress, or higher blood pressure. And then there are also studies showing that people tend to engage in less healthy eating, or when exposed to stigma will eat more. There's less of this work with internalization, in part because it's hard to experimentally induce this in the laboratory. But this is where more research is needed. And certainly from the study that I did recently, we don't know why it is that these associations were found.
Okay. That's interesting. And so does that make you want to do more?
Oh, absolutely.
Is this study getting more media attention than your previous work?
It is. And it's a good question. I'm not really sure why. I think there has been more attention in the press just generally, I think, to this issue, which has been very encouraging. The media in general tends to cover things related to weight. And so maybe it's just a shift from covering all weight loss kinds of stories to also including a smattering of weight stigma kinds of issues. which is very encouraging. And it's nice to see these kinds of issues getting more public play.
Yeah, I did notice there was a lot of articles about your study in media in the UK more than here, which so far.
Interesting.
So what do you feel like is the main finding of this work that people should really know?
I think the main take home here is that more and more research, including this study, is really highlighting the negative effects of weight stigma on health. There still seems to be this misconception among many people that stigma is necessary or even helpful to motivate people to change their health behaviors or lose weight. And over again, we find that that just is not the case, that weight stigma in general is leading to the opposite effects, that it leads to less healthy behaviors, to more stress, which affects mental and physical health. And what this study is emphasizing is that when folks internalize those stigmatizing messages, it may also be associated with worse physical health. So not just psychological consequences, but real effects on people's health and well-being. So I think it's important for the public in general to think about this issue the next time, they feel an impulse to make a comment to someone about their weight or say, well, you could just lose the weight if you really tried, to really think about how the messages that people are exposed to on a daily basis may actually have the opposite effect than what's intended.
Yes.
I work in a bariatric surgery clinic here as well. And so often the reasons that people state for seeking bariatric surgery, in addition to the health benefits and wanting to be able to run around with their kids or their grandkids, it's that they don't want to be limited. And unfortunately, wanting to go to an amusement park with your kid is really off the limits if you're above a certain body weight. And the way that the environment is set up is not inclusive to people of diverse weight statuses.
I've been thinking a lot about bariatric surgery lately because of the celebrities that have been out there in the world expressing their desire for us to shift the way we look at larger bodies and to be more positive about it, and then making the choice to have surgery. I'm curious about, though, something you just said. From what the research I've seen, when you have bariatric surgery, there's very often a high risk of having more physical problems with digestion. And there's a lot of things I've read. But I wonder, when you factor in this weight bias, that you may not experience that at the same level. Do you think there's something there?
It's a really interesting question. And I think when thinking about these issues, there has to be a nuanced approach. So first, as far as the physical complications, certainly with any surgery, there is a risk of complications. The weight bias issue is interesting because I've heard several patients report noticing that they were treated differently after losing the weight. And then they maybe hadn't realized how poorly they had been treated before. And it did kind of make them think differently about some of their relationships or the people that they were working with, when all of a sudden they were being smiled at more or treated in a more positive way. As far as internalization, we don't actually know what happens to internalized weight bias after weight loss just generally, but especially after massive weight loss like that. So this is something that I'm very interested in researching, because certainly there are physical outcomes that come with surgery. And if people have, especially if they have serious health problems and those are alleviated by surgery, then overall they feel better, their quality of life improves. But there is not a lot of research on this issue of what happens to experiences of weight stigma and the internalization of that stigma as a person's body weight changes so drastically.
Are you familiar with Catherine Fliegel's work?
Yes. Mm-hmm.
So I'm kind of curious, and when you're talking, I'm thinking a lot about her work and how the wealth of research that she studied showing that more and more in the obese categories, overweight categories, the health risks and links to dying are not as high as the world wants us to think. But I guess my question is, it seems like a lot of your work is assuming that being at a higher weight is not healthy.
I don't think my work assumes that, because I certainly don't assume that. Weight is not a direct indicator of health. And, we can't tell by looking at someone what their health behaviors are or what their health status is. So I would not say, that from seeing someone with a higher body weight, I would assume that they have health problems. I would disagree with that completely.
Good. I'm glad to hear that.
Yeah. So Sliegel's work is pretty controversial, and there are other researchers who kind of have hypotheses of why she might be seeing those effects. And I won't get into the technical pieces of it. I think it's still something that people are continuing to examine. My understanding of her work is that the class 1 obesity, or the lower levels of obesity, she's not finding those associations. Those associations are still there at the highest levels of obesity, so class 3 or severe obesity, and those are the folks who are coming in for bariatric surgery. There is, to be a candidate for surgery, you have to have a high BMI and or health comorbidities like diabetes. So, in terms of the bariatric surgery, I think her work still lines up or is consistent with those health recommendations. But no, I certainly agree that, for example, when patients come into the physician's office and a physician might right away just start lecturing them about how they need to lose weight or how they need to start dieting without asking any questions about, well, what is your physical activity schedule like, or what are you eating on a regular basis? I think that those behavioral questions are key to really understanding, what is a person's health picture looking like.
Can you imagine a world without that stigma? I'm just started to think about that. If we didn't have this stigma as a society, would these health concerns that have been mislabeled to people with higher weights, like cardiovascular and diabetes, would those things just be more fluid through and not connected to weight if we didn't have that in our world at all?
It's a good question. I think certainly the way that the discussion around obesity right now is, it often talks about those health risks as a burden on society, right? So oftentimes people will talk about the cost of the healthcare system, and it really kind of feeds into this blame toward people with higher body weight. So I think that discussion, if people weren't viewing obesity or weight as, a personal choice and within individual control, then, if that bias went away, then we would see less of that framing. It's an interesting idea that just, when anyone goes into the doctor, they're asked the same questions about their behaviors. They have the same tests, regardless of their weight, in order to screen for health issues. I think it's an interesting idea.
I'm curious about your feelings and use. It seems like you're using BMI a lot in your work, which I know BMI has become a bit controversial, and I was just curious to hear your thoughts on that.
BMI is not a perfect measure of weight status or of health. It's pretty widely known that it's flawed. It's more of a logistical thing, I think, is why it's so widely used, that it's an easy way of estimating a person's weight status or health risk, because height and weight are, simple to measure, or you can have self-reported height and weight, so you can do large-scale studies and use these assessments. There are obviously much better assessments of health, but they're much more costly and time-consuming to get, percent body fat or other kinds of DEXA measurements, even the blood tests and whatnot. So I think it's good that more and more people are starting to really examine BMI and to remind everyone that this is not a cut and dry, tried and true way of distinguishing people based on their health status. Mm-hmm. There are imperfections in it. And at the same time, I think there's definitely room for development of better measures that are also going to be logistically feasible to include in these research studies.
I guess I'm even more curious about that because for me, there is a bit of weight bias in just using those categories and those words. I don't know what my BMI is, and today when I was creating these questions, I was like, I'm going to see what I'm at. I don't really know how much I weigh, so I was just kind of guessing. Immediately it says normal weight, healthy.
Yeah.
And then it's like overweight, unhealthy. I was trying to see the number that was putting me over to one category versus the other. And it was so crazy that it's 1 pound. So within, 1 pound is drinking a big thing of water. Suddenly you're unhealthy. And then it just seems like these categories are so problematic.
Yeah, no, and I think we do need to be much more careful about how we throw around these terms of normal weight or healthy weight versus unhealthy weight. And I think it's something that more and more attention has been drawn to. And, I know some people point out that even the term overweight suggests that you're not at the weight that you should be, right? Because of that word over, it's in some, comparison to some ideal weight that you are not.
Right.
So there has been more and more attention around this language issue, which I think is warranted.
Yeah. Do you have concern in your own work about using the word obesity?
Yeah, so I'm in a medical setting, and so obesity is a medical term, and this is a pretty controversial issue. So a few years ago, the American Medical Association declared that obesity is a disease, part of which was for treatment, right, so that insurance could bill for it and people could get treatments that they wanted. But part of it also was the idea was that this would take the blame off of individuals, that if this was considered a biological disease, then it would be seen less as a personal choice or of an issue of a lack of willpower or personal failure. I think there's more research that's needed to understand how it is that calling obesity a disease and using the word obesity in and of itself affects stigma. So on the one hand, it might reduce blame and the idea that it's controllable if it's medicalizing it. But certainly others assert that it's, just highlighting that this is a disease and that people are unhealthy, and that might perpetuate this, war on obesity. So I think it's an open question that we need more research on to know how it is that it affects stigmatizing attitudes or internalization of stigma. There have been studies about what patients prefer to have their weight referred to as. And those studies generally show that people don't like terms like morbid obesity or even obesity, and that they prefer more neutral terms like weight or BMI even, because it's just more neutral. So I think regardless of what, we as medical providers are using to discuss weight, when we're interacting with patients, we can ask patients, well, what terms are you comfortable with? Is it okay if I use the word obesity? Would you prefer if I use a different term? Certainly on an individual basis, to make sure that patients understand why it is that we're using the terms that we're using, and that it's not meant to be a negative judgment or pejorative to them. It is tricky because, I fill out billing forms and have insurance printouts that always say morbid obesity, even when I type in something different. And that's always awful to have to give to patients and explain to them, sorry, this is just the term that's used by the insurance company.
Is the term obesity, when you're talking about it being classified as a disease, is that directly connected to BMI? How do you measure somebody as obese?
So there are different measurements or classifications of it. So BMI is part of it, but it often includes health status as well. So I'll give the example of class 3 obesity or severe obesity, which could be a BMI of 40 or above, or it could be a BMI, I believe, of 35 or above with a health comorbidity, so with diabetes or with sleep apnea or something like that. So it's a combination of BMI and actual medical comorbidities.
Okay. I feel like it's interesting that you use that word within your study when it's can have so many associations to weight bias. I just wonder if you've been questioning that.
Yeah, and I think it's a good question. Again, within the medical profession, this is kind of widely accepted as the term to use. And there is an emphasis on using people first language rather than using phrases like the obese or, things like that are more stigmatizing. The emphasis is on, it's an individual first, and they're not defined by whatever their health status is or whatever their weight is. And I also am working in even with this study, it was treatment-seeking individuals. So these are folks who might have, medical comorbidities or have more health-related reasons of why they're seeking weight loss. But I sometimes I'll say higher body weight or use more neutral terms. And I think it's certainly something that we need to understand and do more research on so that we fully understand the impact of these terms on people.
Well, I know you talked about, from this last study, some things you found that worked to help counter the weight bias stigma. What were some of those findings?
Yeah, so we did a pilot study last year where we applied cognitive behavioral treatment techniques to try to reduce internalized weight bias. So these are techniques like examining one's interpretation of events and trying to change the way one is thinking about an event in order to change one's feelings and one's behaviors. So an example might be receiving a negative comment from someone else about one's weight, and rather than internalizing it and blaming oneself and feeling badly about oneself because of those comments, changing the interpretation as, well, that person is ignorant or is biased or, having some other kind of interpretation that's leading to a less internalizing response. And then also talking about how do you respond in the moment when someone says something like that so that you feel like you're maintaining your self-respect, you're standing up for yourself, rather than feeling like people are treading over you or disparaging you. So we did a small pilot study where we had an 8-week program with a group of folks who had high levels of internalized weight bias, and we compared it to a quasi-control group of patients who did not receive any intervention. And by the end of the 8 weeks, we did show a significant reduction in weight bias internalization on the weight bias internalization scale, as well as less endorsement of negative stereotypes. We also found that folks who received the intervention had greater self-efficacy or more confidence to eat healthfully, which wasn't something we were targeting in the intervention. It was really focused on their thoughts and feelings about themselves, although we did discuss how weight stigma can negatively affect health behaviors. So we had some really promising results. It certainly needs to be replicated in a larger scale study. But the idea as a psychologist, there's lots of treatments out there for mental health disorders, and we have a lot of knowledge about how to challenge people's distorted thinking. And so the idea here was to try to utilize some of those techniques to apply it to the distorted thinking that goes on when people are internalizing weight bias and beating themselves up because of their weight.
In the fat shaming linked to greater health risks study, is there a percentage you saw, or what were there specific numbers that you can talk about from your results?
So we had 178 adults who were involved in this bigger study, and of those, 159 participants completed our assessment. So we were working from a sample of 159 participants. And of those, about a third of those participants met criteria for metabolic syndrome. The overall scores on the weight bias internalization scale were actually a little bit lower than we see in other samples of treatment-seeking individuals. And one hypothesis for that is that this sample was actually mostly Black women, and most of the weight stigma research has been done more so in white women. And there is some evidence to suggest that Black women may have lower levels of internalized weight bias. And that was the case in the study, that our Black participants did have lower levels than the white participants. So that's something that also I think is really important for future research, to have more diverse samples to really understand the intersectionality of, different kinds of identities as they relate to different forms of stigma. The folks who had those high levels of weight bias internalization had the 3 times greater odds of having metabolic syndrome and 6 times greater odds of having high triglycerides.
So it's more like you were taking a population and looking at it in not over time, but just over where they were at that moment. Is that right?
Exactly. Okay. It was just cross-sectional. So, this was a weight loss seeking sample. So at some point, once the study is fully complete, I am excited to look at how do those things change as a person loses weight. And this is a pretty long-term study, so we'll have some rich data, hopefully.
Yeah, how long is the study go on for?
We're just finishing up data collection, and it's a blinded study, so there's all sorts of processes that have to go in terms of cleaning the data and unblinding the study. But there were 3 cohorts of participants who each were in the study for about a year and a half. So overall, it was over a 2-year study. So everybody, the weight loss part of the study was designed such that people lost weight for 3 months, and then we're in a year-long maintenance phase. So the real focus of the overall study was to examine treatment for maintaining weight loss, which we know is typically, not that weight loss is easy, but the maintenance piece seems to be the most challenging part of not just losing the weight, but being able to keep it off in the long term. We know that that's really...
It's nearly impossible, right?
It's really hard. I mean, the majority of people do regain weight during the year to 3 years to 5 years following treatment. So that's really where a lot of the treatment efforts are now, to try to figure out better interventions to help people keep the weight off. And I think that in and of itself is important for the public and healthcare providers to know, that telling someone to lose weight, first of all, we know it's really difficult to lose weight. And second of all, we know that our treatments are insufficient for helping people keep it off in the long term. So it was a very long-term study that each participant was in the study for, a little less than a year and a half. So we should have the data collection completed soon.
And what was the mode of weight loss in that study?
So at the start, all participants went through a 14-week behavioral weight loss program. So they attended weekly groups, and they were also provided with meal replacements, so shakes, portion-controlled diet. And then after that initial time period, they were randomized to receive a medication that was intended to help with the maintenance. So it's interesting because I've never been involved in a study like this before, and really my role was my interest in this was to have the stigma measures inserted. So it really provides an interesting opportunity to look at how stigma might change or how stigma might affect weight loss outcomes in this mode of treatment.
I imagine it's harder to fund shame studies than it is weight loss studies.
Yes, I think it certainly is different sources of funding, for sure.
So you're able to kind of attach your work to something that's already existing.
That's what I was able to do in this case, yeah.
I was just kind of digesting what you were saying about the study that you did with weight loss. I'm feeling so curious about those studies that still exist, because it seems like over and over and over we find that in the high 80s, 90% people aren't able to keep off weight. It's just, is there still just this continued trying of the same things that have failed over the years?
Yeah, well, I think that's why there has been a big shift to bariatric surgery, because that really is the most promising treatment in terms of more substantial weight losses and helping people keep it off more in the long term. These studies are still going on because certainly prevention has also there's been a greater shift toward prevention because of this understanding that once a person enters into that category of obesity, it's really hard to get out of that category. And so that's why prevention efforts have really grown. But at the end of the day, there are still folks who have obesity, have health consequences that they're suffering from, and things like sleep apnea or, impaired mobility, diabetes. Those things do still require treatment so that people aren't suffering with them on their own. So I think that's why people are continuing to try to advance new developments and, have more treatment options available, and not giving up on those folks who are still suffering from these health problems and need some help with them.
I just think, what if we just took that population and fed them with this psychological positivity? I just wonder how much their health would change if we took out the physical.
I will say, I think it's undeniable that there are real physical health problems that come with being above a certain weight. And so, when you talk to people who have BMIs of 50 and feel out of breath and have a hard time getting around and are hooked up to CPAP machines at night and have to worry about their insulin levels, there is a medical necessity. And I think it's very tricky with, the weight bias and health issues to have a nuanced approach to it that, I think sometimes people think that the ideas of weight bias and weight loss or obesity treatment are contradictory. And I don't see them that way. So there's a mode of therapy called Dialectical Behavior Therapy, or DBT, where the core dialectic is of acceptance and change. And the idea of a dialectic is that you have these two things that seem like opposites, and what you're actually striving for is a synthesis to have both at the same time. So as far as obesity goes, you can at one time be fully accepting of who you are, love yourself for who you are, and at the same time want to change your health behaviors, maybe want to lose weight in order to enhance your mobility or, help with other health issues. And the acceptance might actually help with the change and vice versa, rather than being mutually exclusive.
Yeah, it's interesting. I feel like I'm just, as I'm entering this world, kind of bringing all these pieces I learned together, and they're like swirling in my brain, thinking about, Catherine Fliegel's work. And then it seems like you're really talking about a category of like people that is not a majority of the population, this, smaller group of level 3 or above in the I hate even talking about the BMI categories, but
yeah, no, I know. And that's why I am pretty skewed, I guess, in that the patients who I see are at this much higher weight category. And, when you're talking with them, you can't deny to them that they're suffering from these medical problems. So I maybe have a different population that I'm talking about versus people who have a BMI of 25 and don't have any kind of health comorbidities, but are categorized as unhealthy just based on that BMI cutoff.
Right. That seems super messed up.
Yes. So I think we're in agreement that, like, especially in that middle area, that there's all sorts of assumptions that are made about people unjustly just because of the way that they look.
Yeah, absolutely. Well, I really thank you for your time today, and I'm super grateful. Is there anything else that you want to throw in there, or do you feel like we are at a complete place?
I feel complete. Thank you so much.
As always, thank you for listening to this week's episode of Everybody Podcast. There's quite a bit to unpack from this week's episode, but the big takeaway for me that I think most of us can agree on is that internalized fat stigma is what's super problematic. Those who don't internalize it don't have the same health issues. So we need to keep on fighting the good fight to stop fat shaming as a society and help those who are internalizing it. If you need help with that piece, I'm happy to share the resources I know. I know some great folks doing work in this area. So please get in touch if you need some help. Until the next episode, take care, everybody.